My name is Philippe Moreau. I'm working at the University Hospital of Nantes in France, and I would like to discuss with you the novel induction regimens prior to stem cell transplantation. As you know, the European guidelines are considering that when patients are eligible for stem cell transplantation, we should proceed to frontline stem cell transplantation immediately for patients less than 66 years of age or fit patients up to the age of 70 years when they are in good clinical condition. We are proposing a triplet induction regimen with bortezomib dexamethasone as a backbone, followed by a single stem cell transplantation and lenalidomide maintenance until progression. Why systematic frontline stem cell transplantation? This is based on the results of at least two recent important phase 3 trials showing that the progression-free survival is improved when frontline stem cell transplantation is proposed. The Emno2 study will be published very soon by Dr. Cavo, the PI of the study, and it did compare the VCD followed by either VMP and no stem cell transplantation up front, or VCD followed by stem cell transplantation. And he showed that the progression-free survival was highly improved when patients were receiving frontline stem cell transplantation. So new data to be published very soon, and important data for sure. And the second study is the Ifm 2009 study published in the New England Journal of Medicine in 2017, comparing prospectively in 700 patients 8 cycles of VRD versus VRD plus frontline stem cell transplantation. And in the two arms of the study, patients received lenalidomide maintenance during 1 year. So the results in terms of progression-free survival are in favor of frontline stem cell transplantation. You can see the blue curve with frontline stem cell transplantation and a median PFS of 50 months, 50, versus 36 months with VRD alone. And interestingly, when looking at minimal residual disease, assessed at that time with 7-color flow cytometry, you see that those patients receive MRD negativity are enjoying the better overall survival versus MRD positive patients. So the goal is to reach MRD negativity if possible, and that will be associated with a better overall survival. When you are looking at OS before maintenance and after 12 months of maintenance at the threshold of 10 to the minus 6 in a subgroup of patients enrolled into the Ifm 2009, you see that definitely there is a better overall survival. So this MRD negativity rate threshold 10 to the minus 6 is associated with a better overall survival for sure. So before stem cell transplantation, we are using an induction regimen. And what are the goals, the aims of an induction regimen? We need to have a fast control of the disease with minimal toxicity so that the patient will be able to proceed to high dose therapy. And we also need to have an adequate stem cell harvest. And obviously, we need to achieve the high response rate and, if possible, the MRD negativity before stem cell transplantation. So currently in Europe, we are proposing the triplet combination. As I mentioned before, the PAD regimen is not widely used, and we are using either VTD, bortezomib thalidomide index, or VCD with cyclophosphamide, or VRD. So these are the most important options prior to high-dose treatment. What about US, in fact? And as you can see on the most recent NCCN guidelines published in October 2019, in fact, the two preferred regimens are either VRD, and we are going to discuss about this regimen, or VCD, bortezomib cyclodex. And when you are looking at the prospective comparison of VTD versus VCD published by the French group 4 years ago, in fact, after 4 cycles of VTD versus 4 cycles of VCD prior to intensive treatment, the response rate are in favor of the combination of a PI and an IMiD, bortezomib and thalidomide versus VCD. Definitely those two regimens are good ones with a high partial response rate, but PR and VGPR were higher with VTD. Definitely the toxicity is not identical with VCD, a higher rate of anemia, of neutropenia, and with VTD, as expected, a higher rate of peripheral neuropathy, grade 2 to 4. What about VRD? We can switch from thalidomide to lenalidomide, and recently the Spanish group published the results of 6 cycles of VRD upfront prior to stem cell transplantation on more than 450 patients. And they nicely showed that the VGPR rate or better was very high after cycle 6, 70% of VGPR rate or better for patients who completed 6 cycles. And you can see that the number of the response rate is increasing from 4 to 6 cycles. And the median number of CD34 positive cells harvested after cycle 3 were good enough to proceed systematically to stem cell transplantation. So an adequate stem cell harvest. Interestingly, into this analysis, the response rate for patients with high-risk cytogenetics was identical to that of standard risk patients, and this is an important information. Up to now, we don't have any head-to-head comparison of VTD versus VRD in a prospective study. We don't have phase 3 comparison, but we can analyze 2 consecutive trials proposed by the same cooperative group from Spain. And some years ago, 8 years ago, in fact, the same Spanish group in the same centers looked at 6 VTD cycles before stem cell transplantation. And they mentioned that the VGPR rate or better was 60%. So keep in mind with VRD, more than 65% of the patients are responding. So the response rate seems to be slightly higher with VRD. And the stem cell harvest was also good after VTD induction. So when comparing these 2 trials, one with VTD published in 2012 and the other one with VRD published in 2019, definitely the toxicity seems to be lower as well with VRD with a lower rate of peripheral neuropathy. So potentially VRD could be equal in terms or superior in terms of response and less toxic. So the Spanish colleagues integrated those results into an analysis showing on the left part of the slide that the response rate is higher with VRD. And interestingly, on the right-hand side, you can see the progression-free survival with VTD and stem cell transplantation in red and VRD and stem cell transplantation in blue. And definitely the 1-year or 2-year PFS is higher with VRD and stem cell transplantation. So what about MRD negativity rates following VRD 6 cycles? 28% after induction with VRD, according to the Spanish results. So a very important MRD negativity rate after this induction and before stem cell transplantation. Can we do better or can we use other regimens? Yes, other regimens are proposed before stem cell transplantation, and carfilzomib is proposed in combination with Lendex. And we have phase 2 data showing that KRD followed by stem cell transplantation is associated with a very good progression-free survival rate. That's only phase 2 study, but KRD was also tested into a prospective randomized study comparing KRD and KCD, carfil cyclodex, in the setting of high-dose treatment. And our Italian colleagues into this Forte study looked at the VGPR rate after induction, and they are showing that KRD is better than KCD, as expected, I would say, and the VGPR rate after 4 cycles of KRD is at least 70%. So definitely a good regimen as well that is tolerable. And when looking at the stem cell yield with KRD, you can see that the median PBSC harvested CD34 positive stem cells was higher than 6 million of cells. So definitely a good stem cell yield as well before stem cell transplantation. But we can also add to a triplet regimen a monoclonal antibody such as daratumumab, and that was tested into the prospective Cassiope study comparing VTD versus VTD plus daratumumab, both before and after stem cell transplantation. So the study enrolled more than 1,000 patients, and when looking at the results of the first part, the induction part, you can see that almost 90% of the patients were able to proceed to stem cell transplantation. So definitely this quadruplet regimen VTD DARA is feasible. And when looking at the response rate, you can see that we have a higher VGPR rate or better with daratumumab versus no daratumumab, and the responses are deepening over time after induction, after stem cell transplantation, and after consolidation as well. So what about the stem cell collection in the DARA arm of the study? As you can see, in median, we have more than 6 million of cells. So again, a good stem cell yield before stem cell transplantation with a quadruplet regimen incorporating a monoclonal antibody. Interestingly, we looked on an intent to treat basis at the MRD negativity rate assessed by flow cytometry, 2 tubes, 8 color flow with a threshold of 10 to the minus 5. And you can see that the MRD negativity rate is 34% with DARA, significantly higher as compared with VTD alone. And importantly, when looking at the prognostic factors for progression-free survival, the most important one was the addition of daratumumab, but another very important one is the MRD negativity after induction. So definitely, when MRD is negative after 4 cycles of induction with VTD DARA, we can predict for a better progression-free survival outcome. And this is a very important information for future trials. And when looking at the PFS, you can see that those patients in green that are reaching MRD negativity with VTD DARA are enjoying the best progression-free survival after stem cell transplantation and after consolidation as well. So definitely with DARA, we are improving MRD after induction, but also after consolidation. You see here the MRD negativity rate, 10 to the minus 5 of 64% with DARA versus 44% with VTD alone. And this translated, this quality of response, the depth of response, translated into a better progression-free survival, as you can see here with DARA, with a hazard ratio less than 0.5. So definitely very good results. And we already, despite a short follow-up, have a trend for a better overall survival with the use of daratumumab upfront before, but also after stem cell transplantation. And this quadruplet combination is now approved by FDA and EMA in the setting of high-dose treatment. When we are looking at patients with high-risk disease versus standard-risk disease, in the DARA arm of the study, you can see that those patients with standard risk in yellow have a better outcome as compared with patients with high-risk disease, despite the use of daratumumab and the quadruplet combination. It means that a quadruplet with DARA and VTD is not able to overcome entirely the outcome, the poor prognosis of patients with high-risk cytogenetics. Those data are not published yet, but they will be reported by Dr. Sonneveld very soon. What about VRD plus DARA instead of VTD? So currently, the Griffin study a phase 2 study looked at this prospective comparison, so very a similar design to that of Cassiope, VRD plus or minus DARA, both before 4 cycles of induction and also after 2 cycles of consolidation stem cell transplantation. And we have heard about the very good response rates after induction in the DARA arm of the study, higher as compared with VRD alone. And the estimated PFS and OS are really impressive in the DARA arm of the study. In purple, you can see that the 2-year PFS is above 95% and the 2-year overall survival above 95% as well. But we also have very good results with VRD alone into the study. The median follow-up is short, and we need definitely a longer follow-up to assess about the impact of the addition of DARA to VRD. And this is also tested prospectively in the Perseus study in Europe, VRD plus or minus DARA before and after stem cell transplantation. And definitely, since VRD is becoming one of the standard of care currently in Europe, VRD DARA potentially will change the game in the future. But what about KRD DARA with carfilzomib into a quadruplet combination? We have heard at ASH recently the very good results of the MASTER study, a phase 2 study, small number of patients, but definitely weekly carfilzomib with LEN and DARA before and after stem cell transplantation, 4 cycles up front, 4 cycles of consolidation after stem cell transplantation, and a systematic analysis of MRD by NGS at 10 to the minus 5. And when patients were consecutively 2 times MRD negative, the treatment was stopped and patients were just observed for response and relapse. And interestingly, when looking at the MRD negativity rate, 10 to the minus 5, after 4 cycles of KRD DARA, 40% post-induction before stem cell transplantation, and this translated into a higher MRD negativity rate as well after stem cell transplantation, 73%. So with VTD DARA, 4 cycles, we have into Cassiope 34% of MRD negativity, 10 to the minus 5 with flow. And here, 40% after 4 cycles of KRD DARA with NGS, 10 to the minus 5. So definitely the quadruplet regimen before stem cell transplantation will probably will be widely used in the future. So to conclude, I would say that induction is an important step into the strategy when patients are eligible for stem cell transplantation. To date, in Europe, VTD and VRD are the best options. KRD versus VRD, we don't know. We don't have yet any results of this comparison. And potentially the role of quadruplet induction will increase in the future, including CD38 antibodies. We know now that MRD negativity rates after induction are a surrogate for the final outcome of patients, but the strategy should always consider not only induction and stem cell transplantation, but also potentially consolidation and maintenance as well. And I thank you for your very kind attention.
Welcome. My name is Philippe McCarthy. I'm at Roswell Park Comprehensive Cancer Center, and I've taken the position in this medical debate that maintenance therapy is mandatory after auto-transplant for multiple myeloma. While not everything has to be mandatory, but maintenance until progression is the right choice. These are my disclosures: consulting, honoraria, institutional research support, and I will be discussing some non-EMA and non-FDA approved indications during my presentation. So what is the definition of mandatory? It's required by law or rules, compulsory. This is from a Google search I just did yesterday. Other synonyms are obligatory, indefinite, imperative, necessary, or required. That's from Merriam-Webster. Antonyms are elective, optional, voluntary, which I would argue against. And thus, I would say that maintenance therapy after auto-transplant for myeloma is strongly recommended. So the intro. So Len maintenance after auto-transplant has been shown to improve progression-free and overall survival in several studies in a meta-analysis. Standard risk patients benefit more, and for high-risk patients, there is some benefit, but we need new approaches. Len maintenance until progression is an approved approach, as mentioned by both FDA and EMA. We do not know which patients, if any, do not need maintenance. In addition to no maintenance, fixed duration Len maintenance has not been proven to be equal to maintenance until disease progression. Other maintenance therapies such as bortezomib, ixazomib, elotuzumab, and daratumumab as single agents have not been directly compared to lenalidomide. This is the meta-analysis that was published back in 2017 from the 3 large studies from the US, from France, and from Italy. And when pooled together, there was a 25% reduction in the risk of death, representing an estimated 2.4 increase in median survival when you compared Len therapy versus no therapy or placebo. There is a chance of risk, I should say, of developing a second cancer, but the risk of developing a second cancer on Len maintenance is outweighed by the benefit of Len maintenance in terms of improved overall survival, despite the risk of the second cancer. This is some other data from the meta-analysis. On the left-hand side, you can see the Kaplan-Meier estimates of progression-free survival 2, or PFS2, which is the progression-free survival on next-line therapy, again, superior for lenalidomide when compared to placebo observation. These are the hazard ratios of 0.72, or a 28% reduction in the PFS2 when receiving lenalidomide. When we look at overall survival, in particular comparing induction regimens, we see that a Len-based induction regimen generates a superior outcome with Len maintenance, but we also see benefit for thalidomide, bortezomib-based, and even anthracycline-based with that. Back when we used to do that in this study. And at the bottom, you can see the hazard ratios for overall survival by individual study, with, again, the hazard ratio being 0.75 overall for the 3 studies. Myeloma 11 was published last year. This is a very large study with thalidomide, lenalidomide-based inductions and one arm with the addition of carfilzomib. And you can see that patients then received lenalidomide or no maintenance. Some received vorinostat. And this shows the progression-free survival for the patients on the study who were considered transplant eligible. This is superior progression-free survival. And for the same patient population, there's also a superior overall survival for the patients receiving lenalidomide. We also saw a benefit by cytogenetic risk groups for standard, high risk, and ultra high risk, although the benefit for the ultra high risk is modest relative to the benefit for those with standard risk disease. And in a meta-analysis, again, combining the 3 previous studies on the previous slides, along now with myeloma 11, the hazard ratio is 0.72, or a 28% reduction in the risk of death when comparing lenalidomide to placebo. The other thing about maintenance is that it is not just maintaining the status quo, but it's also therapy. And this is from myeloma 11, showing that there is a 32% conversion rate from MRD positive, minimal residual disease positive, to MRD negative at 6 months in the bone marrow when compared to only a 4% for placebo. This is the Emno2 study, another study where all patients received lenalidomide, and at 2 years, among the MRD positive patients, 48% of them will become MRD negative with lenalidomide maintenance. This is BMT CTN0702. The study has been presented in abstract form, and also showing at 1 year the conversion rate for those patients who at day 100 are MRD positive. At 1 year, 37% of them will become MRD negative. So this is very important to realize that maintenance isn't just maintaining, it also is treatment. This is a busy slide, but it's meant to show all the different consolidation maintenance regimens in the PFS in transplant-eligible, newly diagnosed myeloma patients. The controls are all in gray. The orange on the orange-red on the far left are patients receiving thalidomide when compared to placebo. The yellow are proteasome inhibitor-based regimens, either single agents or as in combination. And you can see from the Hoban, German, Nordic, Spanish, Italian, and then the recent oral agent, ixazomib, there is a benefit for bortezomib or ixazomib-based regimens for maintenance consolidation. This is the Ifm, which terminated maintenance therapy due to second cancer risk. There was a concern, 41%, and then, 41 months. And you can see here about 50-month benefit when compared to placebo, where the time was approximately 27 to 28 months. And you can see a benefit for all the patients receiving lenalidomide until disease progression when compared to placebo. This is another slide showing fixed duration. So here we again compare the 0502 study where lenalidomide was stopped early on an average time of about 2 years. These are the US, the Italian, the meta-analysis of myeloma 11, as well as the Emno2 where all patients got lenalidomide. There's no control arm, and you can see the gray control arms, and you can see a marked benefit for len until progressive disease. If you look at Ifm 2009, which was 1 year only of len maintenance, it's not quite as good as the other studies. Again, not quite an inter-study comparison, but just showing the different studies. GMMG, which was 2 years of len versus, and GMMG also looking at len until CR and then cessation. Again, showing a better outcome in the patients receiving len until progression. This is the blue and yellow, the Swedish flag, and this is our Swedish hockey player in Buffalo, for the Buffalo Sabres, Rasmus Dahlin, who's quite good. So what's for the future? We know that the Forte trial presented the results. I won't go over them in detail regarding induction regimens, but on the back end, they have not yet reported, but will in the future, the lenalidomide versus lenalidomide and carfilzomib maintenance. The Griffin trial, which is in press, again, the results of the consolidation showing a benefit of the addition of daratumumab to RBD induction consolidation. The maintenance portion, which is dara-len versus len, has not yet been reported. The GMMG HD6, looking at an ELO-based consolidation and then maintenance. The Cassiopeia study was reported and published last year, showing a benefit for DARA VTD versus VTD. There's a randomization later on to DARA monotherapy versus observation, and we await those results over the coming year or two. There is 2 ongoing studies. The EMN, excuse me, is ixazomib-based maintenance versus DARA ixazomib, and that study's ongoing. The SWOG 1803 trial, it's a little bit complicated. These are any induction regimen. And then it's lenalidomide until len-dara and len versus len-dara. And then at 2 years, those who are MRD negative are randomized to continuing len versus stopping. Same thing with the len-dara arm. Those are a positive continue. It's a little bit complicated. It's an 1,100 patient study. 81 patients have been accrued. My concern is that the estimated accrual is still a long time, 10.8 years, and will be doing the same thing several years from now while the study is accruing, and that remains to be determined. There are other studies. This study is the Spanish trial, which is ongoing. It's Len-Dex ixazomib versus Len-Dex for 2 years, Mrd testing, and then stopping or continuing to based on bone marrow MRD positivity. This is the Perseus trial, which looks at a 4-drug versus 3-drug regimen similar to the Griffin trial, and then a consolidation, except this arm is completely Dara and this one is not. And then Len is until PD, Len-Daris for 2 years, and then a continuation of therapy if MRD positive versus MRD negative, and then stopping at 1 year. This is a complicated UK MRA study. I won't go into it in great detail, but for standard risk, there's a different approach if you're MRD positive versus MRD negative versus stopping it for MRD negative versus continuing therapy. For high risk, there's continued treatment because these patients are at higher risk even with Len maintenance for progression. This is a proposed IFM 2020, which is a complicated algorithm with a transplant versus chemotherapy and a monoclonal antibody, and then 2 years of maintenance on the back end with a combination of 3 drugs versus 2 drugs. So, in summary, lenalidomide after transplant until disease progression remains standard of care. There's no phase 3 study supporting observation or no maintenance for any subgroup post-transplant. We need to understand which patients are at risk for second cancers and reduce adverse reactions. Lenalidomide maintenance can convert the patient's bone marrow from MRD positive to MRD negative over time. And this is an important thing to remember, that it's not just maintaining the status quo, but the patients who are MRD positive, we have actual evidence that is treating that MRD positivity and making some patients to go to an MRD negative status. For those who are below the level of detection, we can just speculate how that is affecting the MRD negative patients. MRD negativity can be considered a surrogate endpoint for PFS and OS, and will it allow for cessation of maintenance? It remains to be determined in the studies I previously discussed. And how deep? Should it be a 10 to the minus 5, 10 to the minus 6? At what time point do you measure it? That after induction, after stem cell transplant, at day 100, 6 months, 1 year? How long do you keep measuring? And there are previous studies from the IFM showing that negative imaging is very important. If you become PET CT negative and MRD negative, you do better than if you're MRD negative but still PET CT positive. We also need to account for clonal heterogeneity. Myeloma is heterogeneous disease, and previous studies have shown that there are occult sites that can be very heterogeneous relative to a random bone marrow sample. The cost of Len maintenance must be evaluated with the cost of earlier progression, requiring salvage and no or fixed duration maintenance. Patients, I didn't have a chance to go over that, but maintenance therapy is cost effective as opposed to having to reinduce a patient and embark on salvage therapy. And I have to mention the time of COVID-19, that right now the recommendations are to continue Len with appropriate blood count checks and telemedicine checks. If on VRD maintenance, consider RD if appropriate. This would be, for example, a high-risk patient population. If a COVID-19 infection develops, hold maintenance until resolved. And this is from the ASH website, which is shown below. I just checked that this morning. So, in summary, Carthage was the sworn enemy of Rome. Cato the Elder ended all his speeches, regardless of topic, to the Roman Senate by saying, Carthago delenda est, Carthage must be destroyed. In the era when median PFS are approaching greater than 5 years and OS 10 years, we need early surrogate endpoints for long-term outcome. They must be tested in clinical trials so as to prevent studies that must remain open for 10 years or longer, especially for an OS endpoint. I'd like to thank the patient caregivers and the clinical who participated in the trials, all my colleagues around the world, my colleagues at Roswell Park, from the Alliance, BMTCTN ECOG, NCI, FDA, my wife who puts up my schedule. I'd like to thank the organizers for inviting me to give this presentation. And thank you very much. Merci beaucoup. Stay safe. Restez en sécurité. Thank you very much.
Hello, everybody. Welcome to COMy 2020, the virtual meeting. I'm Professor Arnon Nagler from Shiba Tel HaShomer, Vice Chair of the Acute Leukemia Working Party of the EBMT, and I will discuss the yes position and defend transplant upfront for all eligible newly diagnosed multiple myeloma patients. So the goals of therapy in newly diagnosed multiple myeloma is sustained deep, minimal, or measurable residual disease negativity. Continuous therapy with upfront transplantation is currently the best available option. And upfront transplantation results in a deeper and longer initial treatment response, as you can see in the slides, and we are aiming to 10 to minus 6 MRD that can be analyzed by flow, usually it's 10 to the minus 5, or next generation sequencing 10 to the minus 6. And we also need, as you know, PET-CT negativity. And we also know that the price of autologous transplant represents a relatively small part of the overall monetary cost of the treatment paradigm today of multiple myeloma. So transplant is in upfront transplantation in myeloma is based on 7 randomized studies. I don't know many questions in medicine that were so well analyzed in studies. And all these studies that were 2-arm studies of transplant against conventional chemotherapy showed improved complete remission with transplant. 6 out of them showed improved disease-free survival, and 3 showed improved in the median overall survival of a year or a year and a half. Now I am sure that my opponent, Professor Lonial Sagar, will tell you that all of these studies are in the pre-novel agent area. But I will show you that this is true also with the best available upfront therapy in 2020. So why transplant upfront? Because it is the standard of care in all eligible patients with newly diagnosed multiple myeloma. And if we look on the Esmo Guidelines for patients below the age of 65 or fit patients up to the age of 70, as published in Annals of Oncology by Professor Philippe Moreau, we need triple drug for induction therapy, which is all bortezomib or Velcade based, can be VTD, VCD, RVD, or PAD. And then Melphalan 200 milligram per meter square, and followed by autologous stem cell transplantation, and after transplant, lenalidomide maintenance. So if we again zoom onto the Esmo guideline, we can see that Velcade or bortezomib is the cornerstone of the induction therapy. We need 4 up to 6 courses according to the recent data from our Spanish colleagues. And you can look on this meta-analysis and see that the progression-free survival is better in this meta-analysis if the upfront regimen, the triplet, contain bortezomib. So I would argue that front-end autologous stem cell transplantation in the standard of care in newly diagnosed multiple myeloma, even in the area of novel therapy. And up to now, there is no prospective trial that has demonstrated the superiority of the novel agent approach over the early autologous stem cell transplantation with the standard, routine, and state-of-the-art. So we have 4 studies in the novel area that compared upfront transplantation to novel therapy. And out of these 4 studies, all of them show better progression-free survival with the upfront transplant, and 2 of them showed better overall survival. First of all, the Professor Palombo study that was published in New England 2014 that compare MPR to MPR autologous transplantation with improvement of also almost double progression-free survival from 22 months to 43 months, an improvement of the 4-year overall survival from 65% to 82, almost 82%. Then we have the Francesca Gay study with compare autologous transplant with upfront cytoxan, lenalidomide, and dexa. Yes, you can argue that we don't have here bortezomib upfront, so this is the limitation of this study, but the results are exactly the same like for Professor Palombo. So the transplant upfront improved progression-free survival from 28.6 months to 43.3 months, and the 4-year overall survival from 73% to 86%. Then we have the pooled analysis of 2 phase 3 studies listed here, again published by Francesca Gay in Leukemia 2017, and again the autologous stem cell transplantation significantly improved the progression-free survival 1 by 18 months, and the 4-year progression-free survival 2 by 20%, and overall survival by 15% compared to chemotherapy. And then we have the CAVO study, which is the AMN 02095, so GMEMA and HOVON, in which patient received upfront VCD, and then there was randomization between autologous transplantation and VMP, and again progression-free survival was better with the upfront autologous transplantation, with hazard ratio of 0.76 with p-value of 0.01, improvement in the VGPR from 74% to 84% with the transplant, again very significant, and this study is not yet published in a full article, and the data for overall survival is not mature. So this is the CAVO study, VCD induction, VMP, and they compared to high-dose Melphalan and transplant, and as you can see here in red, improvement or better progression-free survival with the upfront autologous transplantation. Now, the most quoted study is the Ifm Harvard study, in which nobody can argue that this is not one of the best upfront novel therapy induction in newly diagnosed multiple myeloma. And this is was published again in New England Journal of Medicine by Professor Michel Attal. And after 3 triple therapies, there was randomization between another 2 courses of RVD or autologous transplant to be followed by 2 courses of RVD. And this is a study that nailed down the importance of measurable residual disease as the best endpoint in newly diagnosed multiple myeloma. And you can see that for complete remission and VGPR, and most importantly for MRD, there is advantage, significant advancement of transplantation compared to the RVD arm, and the transplant improved progression-free survival from 36 to 50 months, so 14 months more. I'm sure that Sagar, Professor Lonial, will tell you that the overall survival is the same, 81 versus 82%, but I will argue that many of the approved novel therapy drugs in multiple myeloma didn't show yet improvement in overall survival. But the most important finding is the measurable residual disease. So it's a huge difference from patients that achieved less than 10 to the minus 6 by next generation sequencing performed by Verduzo in progression-free survival to those that did not achieve this cutoff point of MRD negativity. And this is also true for overall survival. So patients that achieve less than 10 to the minus 6 MRD has a better overall survival with a p-value of 0.008. And this is the progression-free survival at a start of maintenance and after 12 months in patients that achieved the MRD negativity and did not achieve MRD negativity as published by the Harvey in Blood 2018, and you see the huge difference both for progression-free survival and overall survival. Now, transplant improved the depth and the length of sustained MRD in all the novel available triple or quadruplet therapies that we have today for newly diagnosed multiple myeloma. And I will go one to one. Again, the RVD, and this is from our Spain colleagues that compare RVD to VTD. This is not the point today that RVD is better, but I would want to show you patients after induction and after transplantation, VGPR and MRD. In this case, it's by fax, and therefore 10 to the minus 4. And you can see here that more patient achieved response and more patient achieved MRD negativity post-transplantation, 74% compared to 63% post-induction, and the same is for the MRD, so 62 compared to 46%. So after autologous transplant, we obviously transplant is not now is a part of all the treatment that we give for myeloma, and after it we have to give the lenalidomide maintenance according to the meta-analysis and the British study, and maybe in the future we will be able to even improve on that, and this is the question in the Auriga studies that combine lenalidomide and daratumumab for maintenance after transplantation. But if we move on, and for the DARA era, and now we have quadruplet, so this is the Cassiopeia study published in Lancet last year by Philippe Moreau, and you can see the DARA VTD compared to VTD and then transplantation. And what you can see is that the DARA VTD improves the strengthened CR from 20% to 29% here in purple. But for the purpose of this talk, we again will look on the response after induction and then after upfront transplantation. And you can see here that complete remission in purple, strengthened CR in light blue, and the VGPR in orange is better after transplantation compared to after induction therapy. And those are the curves for the DARA VTD compared to VTD, improvement in progression-free survival and not yet in overall survival. If we look on very similar study, but now the DARA RVD by Griffin et al., again, DARA RVD compared to RVD to be followed by transplantation. Again, the stringent CR is better with the DARA RVD, 42% compared to 30% with the RVD. But for my talk today, the upfront autologous transplantation, again, stringent CR is 21.2% after the transplant and only 12% after the induction triple, the best induction therapy, or one of the best that we have today. And these are the curves for the progression-free survival and the overall survival on this study. Now, the best maybe upfront therapy is the weekly carfilzomib with daratumumab. So weekly carfilzomib, Revlimid, and Dexa with Dara. So this study was presented in ASH in December from Birmingham by Costa et al. And this is also the study that was based on MRD evaluation. So you can see that the response rate with this very potent upfront therapy is very impressive, 100% with or without transplantation. But if you look on MRD, which is the most important endpoint in treatment today of myeloma, you can see that MRD 10 to the minus 5 was achieved in 34% after induction and 70% after transplantation, and MRD 10 to the minus 6, so important as we saw in the ATAL study, is only 28% after induction and 45% if we combine with upfront transplantation. And patients that achieve MRD negativity and are negative in PET-CT are cured and can stop therapy. So we all talk about the Forte study, and maybe we can abandon the transplantation. So in this study, again, Francesca Gay compared the KCD to KRD, but this is not the point of the talk. And then there were two arms of KRD versus KRD and transplantation. So KRD, very potent, one of the best upfront therapy. And look again, although the response, as you will see, was very good with KRD, early relapses, so less than 18 months, was better for the patients that underwent upfront transplantation, 8%, compared to 17% if you omit the transplant, or in the arm without transplantation. The risk of early progression was also reduced by the transplant with hazard ratio of 0.42 and a p-value of 0.21, and this was mainly in high-grade multiple myeloma, so RISS 2 and 3. So you know the response rate with KRD is with transplant or without transplantation is quite similar, I have to admit. But if we look on the MRD, again, MRD with upfront transplantation KRD is better than without transplantation. And this was the topic of another paper that was presented at ASH in December that focused on the MRD in the Forte study, exact what we want to see. And you can see here that if we look on MRD by flow cytometer 10 to the minus 5 or by next generation sequencing with cutoff point of 10 to the minus 5, I mean, you see that it's 78% with KRD, 85 better with combining with upfront transplant, 48% with KRD, better with transplant. And the most important one, as you know already, is 10 to the minus 6. And this is, again, better with transplantation, so 34% compared to 23%. Now, the cost of multiple myeloma treatment is very high these days, and this is decision analytic model, not in the time of the novel therapy. Of course, novel therapy costs much more money. Upfront transplantation was cheaper. Upfront transplantation increased the quality adjusted life years of the patient, and two-way sensitivity analysis of overall survival and the overall response shows that early transplant is the preferred treatment option for all probabilities almost. Now, so we conclude now that for newly diagnosed multiple myeloma, you need very potent induction therapy, or RVD or KRD. It's better if you combine it with daratumumab, not yet approved. MRD is the most important predictive factor for future therapies. And then you need transplantation upfront, and according to the CAVO study in high-risk patients, also double transplant. Consolidation, we don't sure these days, and then lenalidomide maintenance or even lenalidomide with DARA. So toward the end, I want to show Professor Lonial, Sagar, one of his papers. I hope that he recognized the paper. And if I quote from the paper, Professor Lonial said, until results from randomized trial comparing early versus late autologous transplant become available, it is recommended that patient and physician consider upfront autologous transplantation because it is complementary with novel drug induction in terms of inducing a high CR rate, and patient can have excellent quality of life. And I show you that now, after 4 randomized studies, this is even we can even have a stronger statement. Also, Professor Lonial continue, after short course induction, it is known that at relapse after transplant, patients typically respond to rescue therapies, whereas the efficacy of autologous transplant after long-term exposure to novel agent remain unknown. And finally, with the demonstration that patients develop numerous new genomic mutation with subsequent relapses, the use of combination therapy and attempts to prolong duration of first remission remain important priorities. And I would say sustain a deep MRD. And this is not from my paper, this is from Professor Lonial Sagar paper. So we can admit that in the future, when we will have a very good biological mutation markers, we are looking for this and talking about this for years, but we are not yet there. So the M-Smart approach for the Mayo Clinic, again, we'll maybe find some group of patients in which upfront transplantation will not be so beneficial, but till now, if you look on the scheme, in most of the patients, still I see here autologous transplant, and autologous transplantation upfront. So we have many questions, and I would say that none of them was answered before abandoning the upfront autologous transplantation approach. What is the chance that we has the transplant if performed late? What multiple myeloma tumor cell harbor? Would multiple myeloma tumor cells harbor more mutation if we wait? What are we losing performing the transplant upfront, as transplant-related mortality is rather low, 2%, and the procedure is very cost-effective and efficient? Is the benefit of transplant remain for patients that undergo delayed transplant? In the Palombo studies, for instance, if we delay the transplant, 30% of the patients don't reach transplantation. In both strategies, we are cryopreserved early in the disease course. So what is the impact of length of cryopreservation? Many questions, and including we are not sure the quality of life is better than after with novel with deferring the transplantation. So I will conclude my talk with this statement that autologous transplantation, which is currently result in the highest depth and rate of sustained MRD negativity and is cost-effective procedure associated with low mortality rate, only 2%, is the standard of care for young de novo multiple myeloma eligible patients. And I would thank you and look forward for the, I am sure, magnificent talk and show by Professor Lionel Sagar. Thank you.
Hello, I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and I'm going to be arguing on the side of no for transplant for all eligible patients. And this, again, is an important discussion to have because these discussions are coming up far more often now with patients. So as we begin this, or as we get to my side of this debate, I wanted to set a few ground rules because I think this is really important when we talk about what my opponent and I are going to say about this question. And so what I want to make sure is that everybody ignores everything that I've written or published before this debate. And the reason I'm saying that is I'm sure that my opponent is going to pull all sorts of quotations or publications or things, particularly old ones that say from me that everybody should be transplanted. And so I think what we really need to do to decide this debate is have the issues brought out here in this discussion and weigh the pros and cons based on the evidence that we're both about to present. And so for those of you who think that I'm a diehard transplanter, I have news for you. I have seen the light and have completely changed my views. All this time in quarantine has allowed me to really change the way I view the role and benefit of transplantation, to really analyze the data in significant detail. And so what you're going to hear from me may be different from what you've heard from me a year ago, maybe different from what you've heard from me 6 months ago. And so don't say that, oh, well, he's just saying that. This is actually a serious attempt to review the data, understand the data, and make recommendations based on my interpretation of the data. And most importantly, I am a reformed transplanter. I was trained as a transplanter. So my views should count double the fact that I'm saying the other side of the argument, as opposed to my opponent, who is a trained transplanter and continues to be the hammer, and every patient is a nail for him as a transplanter going forward. So let's start talking about what we really know about transplant and about the pieces of transplant and how they fit in the context of multiple myeloma. So the first statement to say is when we talk about stem cell transplant for myeloma, we're not talking about a real transplant. This is the patient's same cells. There's no transplant maneuver. It's really just about giving high doses of Melphalan. And when we talk about Melphalan, remember, Melphalan is a drug first used in cancer in 1961. 1961, that's 50 years ago, was the first time we realized that Melphalan may be an important drug. And also remember, Melphalan is a derivative of nitrogen mustard. These are the things that we used to use in World War II as threats to our opposition. So this is really what we're talking about when we talk about transplant in the face of myeloma. Now, more importantly, the stem cell transplant, if you will, is really a way to rescue a patient from life-threatening myelosuppression as a consequence of high-dose Melphalan. So it gets this sexy name of transplant, but in reality, it's a way to reduce life-threatening complications associated with giving a 55-year-old drug in the context of transplant. All of these trials that people have used to demonstrate the benefit of transplant used what I would call seriously old induction therapies: VAD, VBMCP, high-dose dexamethasone, M2, all of these regimens that most of the people in the audience don't even know what they are anymore. That's what we used, and that's all we had. And the conclusion of those trials is not that transplant is better, but rather that high doses of chemotherapy are better than low doses of chemotherapy. So put that context in your mind as you begin to see some of the data that I'm going to show you in the next few slides. And of course, just to put it as a reference, this beat up old car down here to me is Melphalan, 1961. We've not changed the way we do transplant appreciably since 1961. It's the same old drug. So these are the two trials that launched thousands of transplants in the world of myeloma. And what you see on the top are the PFS curves, and what you see at the bottom are the overall survival curves. And both of these trials, using bone marrow grafts in the Ifm study on the left, and stem cell grafts using the MRC trial on the right, demonstrate clear-cut benefit in terms of remission duration for patients who received intensive therapy with a quote-unquote transplant versus standard therapy. So high-dose chemo is better than low-dose chemo. And both of these trials demonstrated an improvement in overall survival. And if you go back to the 1996 trial, this difference in OS was pretty clear when you really had nothing to give patients when they relapsed. On the other hand, in this MRC trial, the difference in OS is not quite the same magnitude as what we see here. Why is that? Because we began to have treatment options for patients after they relapsed. So while the benefit is still there in terms of both PFS and OS, the magnitude of benefit is beginning to narrow a little bit. Now, what accounts for this difference and benefit of high-dose therapy over low-dose therapy? And it really boils down to a much higher rate of VGPR or better, a much higher rate of complete remission. And so this right here is the insight that we need to potentially supplant transplant down the road. If you have treatments that achieve much higher rates of VGPR and CR rate, then perhaps you don't need the transplant because the low-dose chemotherapy very rarely gave you that benefit. So what has changed between 2003 and 1996 and now, almost 20 years later? Well, I would argue pretty much everything has changed in myeloma. We have drugs like bortezomib, lenalidomide, daratumumab, elotuzumab, carfilzomib, pomalidomide, panobinostat. We less likely use alkylators anymore now because we know they are less effective. Even when you combine them with new drugs, VCD is inferior to VTD, VRD, KRD, IRD. You can pick any IMiD-PI combination you want. The addition of alkylators actually doesn't make it as good as the IMiD-PI backbone on its own. We also now have MRD testing, so you can choose whatever method you want. I'm not willing to argue flow versus PCR versus next generation sequencing here. You can choose whatever you want, but MRD testing is the new complete remission. And so the goals of achieving MRD negativity, no matter how you get there, are important endpoints. And finally, we are now all big believers in continuous therapy, particularly in the post-auto transplant setting. And so if you're giving continuous therapy to both the treatment arm and the transplant arm, have you now equalized the playing field, given that the rate of complete remission and MRD negativity is significantly better with our newer treatments? So if all these things have changed, why are we still doing the same thing? So, and again, why not go for the new car instead of that beat up old car that I showed you before? So let's talk about the most recent trial that has been demonstrated to look at the role of transplant using a more modern induction regimen, the VRD regimen overall. And as you can see, this is the Ifm trial, and again, published recently in New England Journal, looking at RVD versus RVD followed by Melphalan on this arm versus just continuous RVD, and both arms received single-agent lenalidomide maintenance. Now, what we all know is that there clearly is benefit in terms of progression-free survival here. This benefit is not as big as one would have hoped, certainly not as big as what we saw in the earlier trials, probably more along the lines of 12 months, something in that ballpark there, but no difference in overall survival. Why is that? Well, probably because this arm is continuing to get len maintenance, and because our salvage therapy options after relapse are far better than they were in the early 2000s, late 1990s. And so the ability to see that overall survival benefit is narrowing, and we may not see it in this trial. And many would argue, if you don't see an OS benefit, what's the real benefit of transplantation? Now, as we begin to think more about not just complete remission, which is here, or stringent complete remission, which is here, but we begin to think about MRD negativity as endpoints, using that same principle that the benefit of transplant was a higher CR rate than conventional therapy, here's where we are. You can look at flow CR at 10 to the minus 5, or you can look at NGS CR at 10 to the minus 6, and see that we are lower and lower on the MRD iceberg, if you will, than in the context of older therapies. And if you look at that same Ifm trial and look at patients that were MRD negative at 10 to the minus 6, whether they were in the no transplant or transplant arm, what you see is that the outcomes are identical. There is no difference in the PFS for people that were MRD negative, whether or not you had a transplant. And so again, does it really matter how you get there? The same depth of response is really what resulted in benefit. Now let's look at another version of this, the Forte trial, which we began to look at KRD with a transplant versus KRD without a transplant here. This is really what I want to focus on because, again, as I said earlier, the KCD arm, the one without lenalidomide, was clearly inferior. Every assessment showed KCD, alkylators, 1961, old-fashioned chemotherapy does not help us, even in the induction therapy setting. And what you'll see is that the VGPR or better rate for KRD initially in aggregate across the board was quite high, and in fact was no different between these two arms. If you then begin to look at transplant versus no transplant, so 12 months of KRD versus just 8 cycles followed by transplant, VGPR or better MRD negative rates are basically the same, 58 versus 54. So are you really getting that bang out of the additional transplant dollar, the additional transplant wallop, if you will, using chemotherapy from 1961? And I would argue the answer is probably no. Now, what do we know about looking at non-transplant studies? And I'm not using this really to suggest we shouldn't be transplanting everybody. I'm really saying, what do we learn about new therapies and the ability of MRD negativity to predict better outcomes? So this is data from the Alcyone trial, where patients either got VMP or DARA-VMP. And what I think you'll see is the rate of MRD negativity clearly higher in the group that receives daratumumab, almost 4-fold higher in the group that received daratumumab compared to the other one. But look at this. This is MRD negativity in the DARA-VMP arm here, and compare that with MRD positive in the VMP arm here, or even MRD negative in the VMP the VMP arm. What again you see is new therapies result in deeper responses, and those deeper responses carry on to better PFS. These are ultimate surrogates for each other, and our goal is to achieve these deep responses, and it doesn't matter whether or not you use a transplant to do that. Let's look at the Maya trial, again, where we take out Melphalan and look at the same endpoint. Again, higher incidence of VGPR or better, that's the benefit of a transplant. Higher incidence of MRD negativity in the DARA arm compared to the Lendex arm, 3.5 times better here, and that translated into a better progression-free survival. And what I would want you to keep track of is the fact that the PFS on the DARA RD arm looks like it may rival the transplant benefit in the transplant patients. And so again, these responses, depth of responses, and durability are far better than what we used to see with VAD, BBMCP, or whatever old-fashioned regimen you needed. And when all you had were those old-fashioned regimens, you needed a transplant to make things better. So how do we put all this together? Well, high-dose chemotherapy is better than low-dose chemotherapy. There's no question about that. But we don't use low-dose chemotherapy anymore. So this is really an irrelevant argument. CR is the surrogate that shows the benefit of high-dose therapy in the short term and in the long term. And MRD negativity is the new complete remission. And so this becomes the new surrogate. Newer inductions achieve higher MRD negativity than older ones. Therefore, the benefit of high dose is less, and I would argue, if at all. I think the fact that we're achieving these high rates of MRD negativity with induction using continuous maintenance, we've now replaced the need for transplant for most of our patients in the newly diagnosed setting. High-dose therapy for all patients is no longer the answer. It may be the question. That's the question we were asked in this debate. But I think for all patients, there's no way to make that argument. And if you ask me if I want that old Edsel that I showed you earlier, or I want this newfangled car, I want the newfangled car. So I think, again, in summary, high-dose therapy is not the answer for all eligible patients. There may be subsets for whom they do gain benefit, but it's not all patients, given that many patients can achieve deep responses overall. And with that, I'll stop and take your questions.
Good afternoon to everyone. Thanks for inviting me to participate to this virtual event. Here, the topic of the presentation will be on the use of anti-CD38 monoclonal antibodies based in induction prior to transplant, if this can be done for all, and I should address the no. So here you can see my conflict of interest, and here you can see my other conflicts, or at least what I would like to say when I have to try to answer to this question. First of all, you have to know that I actually believe in monoclonal antibodies. They are great drugs, that I'd like to use them in the upfront treatment strategy for newly diagnosed myeloma. And we have to consider that most trialist groups are currently evaluating monoclonal antibodies upfront. Nevertheless, my task here is to see if the answer to this question can be no. And to do this, I think we have to focus on a couple of words in this question if anti-CD38 antibodies induction can be used for all. And these words are induction and for all patients. So if we want to see if it's worth to use the drugs as induction, we have first to consider what are the goals of induction therapy. They basically are to achieve a rapid and deep response with a tolerable regimen that allows an adequate stem cell collection. And starting with the data that we have on the ability of this combination to achieve disease control, we know that the current standard of care is combination of proteasome inhibitors and immunomodulatory agents. And you see that these combinations were able to induce good response in quite a good proportion of patients. Of course, if we have a fourth drug, and specifically the anti-CD38 monoclonal antibodies, we have randomized studies that showed that the rate of response increased. Nevertheless, we have also other studies that are using 3-drug regimen, for example, the second-generation PI carfilzomib in combination with lenalidomide, that show to be able to provide high rate of response, and with all the limitations related to the comparison between different trials, you can see that response with this triplet of KRD is somehow similar to the response that you can achieve with quadruplet of first generation PI, lenalidomide and anti-CD38 monoclonal antibody. However, one can of course argue that adding a fourth drug will improve the response, and again, this is true. You can see an increased depth of response with four drugs, with again the limitations that we cannot compare the data coming from different trials. So I decided to focus on the randomized studies that we have and that combined monoclonal antibodies with standard of care. I think you know very well this study, the Cassiopeia study and the Griffin study, adding daratumumab respectively with to bortezomib, thalidomide, dexamethasone, or to bortezomib, lenalidomide, and dexamethasone. And you can see that with the four drug combination, that's true, we have higher rate of high quality response, specifically post-consolidation, but also after induction. Now, looking at the tolerability of these regimens, and in particular the toxicities again reported with the Cassiopeia and the Griffin randomized study, we see that adding a fourth drug, the anti-CD38 antibody, you can see that we have an increased rate of hematologic toxicities, grade 3/4 thrombocytopenia and neutropenia. Nevertheless, despite the high rate of grade 3/4 neutropenia with the combination, the rate of grade 3/4 infections between the two arms is comparable, meaning that the regimens were manageable. Looking at the third point, the stem cell collection, and again the randomized studies, you can see that with the four drug combination, you can collect a sufficient number of stem cells to proceed to transplant, lower with the fourth drug compared with the three drugs. And it's required Plerixa for use in a higher percentage of patients in both studies, but the product of the stem cell collection is good because there are no real differences in terms of engraftment post-transplant using the monoclonal antibody before the stem cell collection or not. So to summarize what we have said so far, we can confirm what probably Professor Mohamad Mohty will show you, that the drugs, the four drug combination is effective, it induced a higher rate of high quality responses compared with the three drug combo. It's tolerable, the toxicity is acceptable, and you can safely collect stem cell. The only thing that I would like to you to focus on looking at these slides is that probably we don't need the monoclonal antibody really for all patients, because you can see that there are patients that can achieve a high quality response even without adding a fourth drug. And you can also see that we use the drug in 100% of patients in all of them, but not all of them can get, for example, into MRD negativity. What is the drawback of a four drug combination? Well, actually is only the cost. That is something that is we have unfortunately to face in real life, and we will have to face in the future. And here you can see how this was nicely shown by Peter Vors at the last IMW meeting, where he showed what could be the expected cost of using four drugs over three drugs, and you can see that the cost of adding DARA to standard of care almost doubled, or you have at least sometimes also three times higher than the cost of using three drugs. And this cost does not take into account the higher likelihood of Plerixa for use with the combination with the monoclonal antibody. The other issue that we may face in using four drug combination in all patients is that it's true that there is an advantage of 4/3 in most of the subgroup of patients. Again, these are data combining effectiveness of induction and consolidation. But you can see that we have the patients with high-risk cytogenetic features, both with DARA-VTD and with DARA-VRD, that have a suboptimal outcome, in particular if compared with standard risk, meaning that the CD38 monoclonal antibody alone is probably not enough to overcome, as there are not enough other drugs, to overcome the adverse prognosis of high-risk features. It is possible that for drug combination with different combinations, such as this one whose data have been presented at ASH this year in 2019, would provide better results in high risk. Nevertheless, the data so far are related to still subgroup of patients, small groups of patients, and need to be confirmed in randomized big studies. So based on all these data that I've shown you, shall we really use all the most effective drugs that we have at first line? And if so, what could be another treatment strategy that can optimize patient outcome? Well, if we want to use all the drugs all together, we should probably try to aim at cure, but it's difficult to cure myeloma patients. So far, we have MRD, which is one of the best marker of long-term outcome, best early marker of long-term outcome, and whose reliability as marker is also supported by the fact that the outcome of patients achieving MRD negativity is similar regardless of the treatment used to get into MRD negativity. And it's the same when you consider, in fact, the use of DARA versus no DARA treatment strategy, because you can see that the patients getting into MRD negativity treated with or without DARA, and these are two studies up front, they have the similar outcome. So the point should be probably not to give all the drugs, but to give the drugs that are needed to get into MRD negativity. Unfortunately, what we have also to recognize is that with the current data, when we have a long follow-up, so we can have reliable data on PFS and also on overall survival, we see that so far also MRD negative patients relapses, meaning that even using highly effective regimens with many drugs, we are still not able to cure the patients. Then what else we know? We know that when the disease relapses, it is possible, in particular at first relapse, to achieve high quality response and also a good duration of remission, because the disease at first relapse, the likelihood of the disease to be sensitive to therapy at first relapse is fortunately still good. And in fact, again, focusing on monoclonal antibodies, since this is the topic of this presentation, you can see that monoclonal antibodies added as part of treatment at relapse were able to improve survival. We're also able to induce high rate of MRD and sustain prolonged MRD negativity. So if these drugs are not used upfront, they can be effectively used at relapse, and in particular at first relapse when the disease can be still sensitive to therapy. And phase treatment at first relapse is something we have to think on when we are dealing with a disease that is not curable. You can see here that the proportion of patients reaching second-line treatment is around 60% overall, considering all the newly diagnosed patients, and it is likely to be higher if you consider subgroup of patients young and patients that receive transplant, because these patients are fit and they have a prolonged life expectancy if compared with elderly patients. So the issue of treatment sequencing is something we have to think on when we plan our treatment strategy for our newly diagnosed patients, and in particular young newly diagnosed patients. And here you can see how one of the major determinant of treatment choice at the time of relapse, as highlighted by these guidelines, European guidelines in 2017. One of the major determinants of the treatment choice at first relapse is the treatment that was administered at first line. And you can see how monoclonal antibody-based treatment in patients that were not priorly exposed to monoclonal antibodies was in fact recommended at the time of first relapse. But how this picture can change in the near future? Well, probably we will have, it's possible based on the data that we have, we will have a wider use of anti-CD38 monoclonal antibodies upfront at first relapse, so patients relapsing after this treatment, and unless there is a treatment-free interval or unless there is a demonstration of efficacy of retreatment or treatment in patients who are priorly refractory, for these patients we will not be able, or we will not be able to use with a high effectiveness again the anti-CD38 monoclonal antibodies. So it's possible that the choice in the near future would be either upfront or at the time of relapse. So to conclude, there are certainly some points that are in favor of the use of anti-CD38 monoclonal antibodies during induction prior to transplant. These are the high quality response, the good safety profile, the fact that you can safely mobilize stem cell, and there are no problem with engraftment. You have to consider that this might not be needed for everyone and that the efficacy in high risk is still suboptimal. Then there are some issues that we have to consider to see if we really need to use them for all patients and to use them continuously, as they have been proposed from induction onwards in several treatment approaches and in several trials. The first thing that we have to consider is that we have a marker that is Mrd negativity that is highly predictive of outcome. So we can think if we should try to modulate the treatment according to Mrd negativity rather than using the same for all patients. So evaluating if we really need them to be used during induction and consolidation, or maybe simply in one phase or for a limited time period. And also if we really need all the patients to get monoclonal antibodies to achieve high quality response. Then we have to keep in mind, unfortunately, that no trial so far showed a survival curve with a plateau phase, that means the cure, so that our patients will relapse, and the likelihood of relapsing in patients with long life expectancy is high. So we should start thinking about treatment sequencing and optimal approach, at least first line and second line. So probably we should try to think more of a strategy that is MRD and risk-driven, rather than one-size-fits-all, giving the monoclonal antibody or another drug to all patients from the diagnosis until the time of relapse. And this could be a sort of an option of a trial that should consider in the different steps of treatment from diagnosis to relapse, both the biological features and the response to treatment. And with this, I'd like to conclude and thank you all for the attention, and all my groups in Torino as well as the Yemen group. Thank you.
So it's my pleasure to participate to this debate as part of the COMy 2020 program. And I'm debating today with Dr. Francesca Gay, who is really the top expert in the field. So I'll try to do my best to convince you all that when it comes to induction prior to auto-transplant in young and fit myeloma, actually anti-CD38 antibodies needs to be added, because we have a strong evidence in favor of using antibodies as part of the induction. These are my disclosures relevant to this talk. I'm sure this audience is quite familiar with the objectives of the induction therapy. We would like, and this is really the most important, to maximize the depth of response. In another word, you would like to minimize the residual tumor cells and achieve the deepest possible MRD negativity. But we don't want to achieve this at any cost. Again, in another word, you need to minimize the toxicities. So the induction prior to transplant in multiple myeloma is really a long story. So I will do some brief I'll show some brief historical data. We've lived for more than 20 years with the traditional VAD, vincristine, adriamycin, dexamethasone. And the Ifm 2005-01 trial, published in JCO in 2010, was the first randomized phase 3 trial which challenged the use of VAD and could show that VD, bortezomib dexamethasone, is actually superior to VAD in terms of response. And based on these data, actually most groups moved into this doublet induction based on bortezomib. And the question was how to do better than VD. One option, or TD for in some places, was to add an IMiD, and that was the idea behind the VTD regimen that was tested at least in 3 major randomized trials from Italy, Spain, and France. And all of these trials could show the superiority of VTD over the doublet induction with TD or VD. But then if we look carefully, we're talking about CR rates maybe between 20 to 30%, depending on the trial, the number of cycles, and so on. And we're not talking about minimal residual disease. Nevertheless, these triplet combinations, especially VTD, proved to be highly effective, highly popular, approved actually in most countries, and over the long term, this triplet induction with VTD proved to be highly beneficial, especially when it comes to PFS, but also, and this is very important to our question today, in terms of PFS too, because using for a short period of time a proteasome inhibitor and an IMiD does not preclude to retreat these patients at time of relapse. The other triplet regimen, also very popular, was the combination of bortezomib, cyclophosphamide, and dexamethasone, namely the VCD regimen. Initially, the VCD regimen was only derived from small phase 2 data, small retrospective series, and you can appreciate the CR rate is quite modest, actually. Maximum reported, but again, it depends on the number of cycles, maybe around 39% if you include near CR. But definitely, when you compare this to VTD, and that is the Ifm randomized trial, you can see we're talking about 10% CR with VCD, 13% with VTD. It's, of course, very good compared to what we historically used to have with VAD, but definitely not ideal yet. Then the question is, why not adding lenalidomide? And instead of having VTD, why not having a VRD? And this VRD triplet has been initially developed in the relapse setting, thanks to the studies from Dr. Richardson, Dr. Kumar, and more recently from Dr. Roussel in France. And here you can see we're probably doing better than VTD and VCD in terms of CR because now we're closer to this 30%. And actually, the large experience from VRD in the induction setting is in the can be found in the Ifm 2009 trial, which has been published a couple of years ago. And this trial used the VRD as a backbone for induction, but also consolidation or continuous therapy, whether you are in the transplant arm or the non-transplant arm. And we know very well from this trial that VRD is a very highly effective induction regimen in this population. The other trial testing VRD is this SVOG trial published by Dr. Jury 3 years ago, which compared VRD to a doublet RD. And what we know from this trial, again, is that VRD really represents a very useful tool and very strong, powerful induction regimen. And I'm not showing the results of these two trials, the Ifm 2009 or the SVOG trial, for the sake of time and because they are already published. But what we know, and I think Dr. Gay would agree with me, is that today, as of today, and for the last few years, we have lived rather well with these triplet induction, VTD, VCD, or VRD. So how can we do better? And this is where the role of antibodies is going to enter into the scene. And this is about daratumumab. So we're all familiar with daratumumab in the relapse setting. So if it works very well in the relapse setting, why it shouldn't work in the frontline induction setting? And that was the spirit of the Cassiopeia trial published earlier this year, or by the summer 2019, actually, comparing, and you can see the design of the trial here, daratumumab VTD to VTD induction. And I will focus on this first part. And what we can see here is that looking into the stringent CR rate, so we're not talking anymore about CR, so we are moving into a higher grade, I would say, in terms of depth of response. We can see that there is a significant improvement in favor of adding daratumumab without additional or safety concerns. And the hazard ratio is 1.6, which clearly suggesting that we have a 60% improvement by adding daratumumab into the induction with VTD. And this will actually already, despite the shorter follow-up, translate into an improved progression-free survival in favor of daratumumab VTD. So based on these data, one question you may ask, why not daratumumab VRD? But unfortunately, we do not have randomized trial between VRD and VTD. So we have to rely on registries and retrospective analysis. And again, to make a long story short, this systematic analysis from Dr. Rossignol, including 2 large Spanish trials and 2 large Ifm trials, could suggest the superiority of VRD over VTD. And actually, that's common sense, I would say. That would be expected because lenalidomide is safer than thalidomide. So in terms of side effects, we're doing better with VRD, but also lenalidomide is likely more potent than thalidomide. So the overall message is that VRD is likely better than VTD. And this is where we have the Griffin trial, randomized phase 2 trial from the US, multi-center, actually presented at the last ASH meeting, but it has just appeared pre-published in Blood a few days ago before COMy. And what we can see, this is the design of this trial, and looking just to the induction, DARA VRD compared to the classical VRD. And what you can see, and looking again into stringent CR, we're talking now about 42% of stringent CR compared to 32%. So it looks like that by using a powerful combination like VRD and adding a monoclonal antibody like daratumumab, we keep on upgrading the response rate that is achieved during induction. And we know already that the response rate that is achieved during induction is going to be beneficial after transplantation. And to make a summary of all the available data, you can see on this table, this is the Cassiopeia trial, DARA VTD. You can see here the Griffin data, DARA VRD compared to VRD, and then we have the traditional VRD data. I'm showing here only the induction results, but these trials also included a consolidation part with the same regimen. And also, I would draw your attention to the differences in terms of the number of cycles, because this is an important parameter. And we know, based on the data from Dr. Blade published in Blood some time ago, that the number of cycles is extremely important. But what you can see here highlighted in yellow, that the best results are the one achieved when you combine daratumumab plus a triplet induction with VTD or VRD. Obviously, these trials testing daratumumab as part of the induction regimen didn't test for the impact of the number of cycles of induction. And I will not talk here. Well, obviously, if you combine, if you replace bortezomib by another potent second-generation proteasome inhibitors like carfilzomib, well, maybe you can further improve on this. So the question is not about antibodies containing regimen versus non-antibodies containing regimen, but it's about how can I further increase the depth of the response. But this is going to be the task of Dr. Gay. So in conclusion, I hope you are convinced that induction regimens prior to auto-transplant have improved significantly over the last 10 years. I mean, with the historical VAD regimen, we were talking about less than 4% CR rate. And now we're talking about stringent CR, but also MRD negativity. Daratumumab and the triplets like VTD and VRD are likely to become standard of care. And by the way, DARA VTD has been approved by FDA and EMA for induction in newly diagnosed young myeloma patient because of this impact of the stringency, high stringent CR rate and high level of MRD negativity. And what's really important and really encouraging for using daratumumab-based induction is that we do not have safety concern or no clinically significant impact on stem cell mobilization. Of course, daratumumab targeting CD38 may impact the stem cell mobilization procedure and yielding less stem cells. However, this is probably not clinically significant, and there are no problems of engraftment. Obviously, and this is part of Dr. Gay arguments, I guess, is that we still don't know what is the optimal number of cycles for induction prior to auto. Is it the historical traditional 3 to 4 cycles, or should we push it to up to 6 cycles, as it has been suggested by the Spanish trial with VRD, or do we need consolidation if we use antibodies frontline and achieve a high level of response? I must also admit that we don't know yet the long-term survival impact. Is it useful over the long term? So all of these questions need to be addressed in future trials, future research. And of course, we should not neglect, and again, I believe this is part of the arguments of Dr. Gay, the pharmacoeconomic considerations, because we're talking about a combination of quite expensive drugs, but I think it's about the value. It's not only the evaluation of the cost of a given drug, but it's the cost of a comprehensive package of therapy for multiple myeloma in order to ensure the longest survival for these patients. With this, I'd like to thank you for your attention. Thank you very much.